So our next topic is by Dr. Awungshi Philamazan. She is mainly working as a pediatric ophthalmologist in Aradhana Eye Institute, Trivandrum, Precise Eye Care, Trivandrum, Geetanjali Eye and ENT Hospital, Trivandrum, as well as Shankar's Eye Hospital, Punalur. She'll be talking on the topic decoding myopia in kids. Over to you, ma'am.
Thank you, Dr. Anjana and KSOS for giving this opportunity. So let's go to the management. We all know what myopia is. So regarding the prevalence of myopia globally, it is mostly confined to the Southeast Asian countries, and it's predicted by the year 2050, 50% of the world population will become myopic. And whereas in India, it's the leading cause of visual impairment, but still, the prevalence of myopia in India compared to that of the Southeast Asian country is still less. So we know it's axial, it can be curvature, lenticular, and if it's more than 6 diopter, it's pathological. There are several risk factors associated with it, and that's what makes the management difficult. So ethnicity, family, genetic factors, excessive nerve work or increased screen time, and reduced outdoor activities plays very important role. So we keep talking about myopia. All the pediatric conferences we go to, we keep on saying, why do we need to monitor myopia? Why do I need to know all of these things? Because like Dr. Anjana has said, it's very difficult to detect in children, also reduces learning ability, poor scholastic performance, and predisposes to strabismus and amblyopia. And every diopter increase in myopia leads to increased chances of myopic maculopathy, retinal detachment, cataract, and glaucoma. So coming to the strategies, we have lifestyle modification, pharmacological interventions, optical and emerging research with repeated low level of red light therapy and 7-methylxanthine. Like Dr. Anjana has said, any kid coming to the myopia clinic or who comes for eye vision test has to be thoroughly investigated. We have to take detailed history, assess the family risk factors, do detailed orthoptics, binocular single vision, and the most important thing is we have to monitor the axial length measurements and keratometry besides retinoscopy. After that, glass prescription will be given like previously described. I usually like to follow them up after 3 months to see how they are coping up with the glasses, then as routinely after 6 monthly. So the main thing about myopia is all of us are having difficulty in monitoring the progression, and hence the impact myopia guideline was formulated, which was published in IJO in 2023. It says we have to identify through axial myope and map the risk factors, pick up those who are progressive myope by monitoring the axial length, and advise appropriate myopia therapy. We have to consult, and monitor regularly. Counseling is very important because the parents may not come back for follow-up. And if we know how to start any treatment, we should also know when to stop it. Hence, in our hospital, we do axial length monitoring of all the kids. Like 99% of the kids, we make sure we do that as long as they are cooperative for the examination. And once we start with anti-myopia treatment, which we'll come to later, we have to do a first follow-up at 1 month to see the side effects or if there's any adverse effects of whatever treatment we are giving. Then second follow-up at 6 months. A good response is said to be if there is less than 0.5 diopter, that is less than 0.1 millimeter in 1 year. Then we can continue the treatment. If it is progressing more than 5 diopter, more than 0.5 diopter in 1 year, then we have to think about combination therapy. So when do we start combination therapy? If one of the therapy is not working, then we can combine them. The advantage is that there is enhanced efficacy because of the synergistic effect, but the disadvantage is that the risk increases as well as the side effects. So several studies have been done where they have combined various therapies, and then some of them have been found to be effective, some of them are still under study. Nowadays, our main focus is on lifestyle modification. We know that reading is a good habit, but excessive reading is also not good, and digital devices and increasing the outdoor activities. So study has been done to study the influence of environment and lifestyle on myopia. In Sydney myopia study, it was found that 2 hours of outdoor activities daily reduce onset of myopia, even if the kids have a lot of near work. And there is a dose-response relationship between how much time they spend outside and the myopia onset and also the progression. So when regarding the light, the outdoor activity is promoted because of the intensity of the light. Indoor, outdoor, they have more intensity of light, so that kind of have an impact on how the myopia progresses. So more myopic spherical equivalence ratio is seen, and longer axial length were associated with kids who spend more time using smartphones. Coming to optical correction, Mrs. Rosemary has spoken about the spectacles and all, but I'm just giving an outline. If optical can be spectacle or contact lens, we have single vision lens and myopic lens, contact lenses, soft contact lens, and ortho K lenses. Each of this management has to be tapered according to the needs of the child. So defocus, if the child myopes with relative peripheral hyperopia, we prefer defocus spectacle lenses or multifocal distance soft contact lenses and ortho K. Individual with high accommodative lag or esophoria for near viewing, we go for bifocal or progressive or EDOF contact lenses. Regarding ortho K lenses, it gives a slight flatter base curve, so that it kind of gives a compressive positive pressure on the central part of the cornea, which causes flattening. And when we do the staining, we'll have this bull's eye effect, and it was first used in 1965. So the advantage of this is that the child can wear this lens at night at bedtime, and then during the daytime they can be spectacle free, because this acts by working on in this part we can see after 14 days of use of ortho K lenses, the central part of the cornea gets compressed. However, it is reversible, and the contraindication would be any eye infection, which is predictable. We won't use contact lenses. And the advantage is that once we stop the treatment, it kind of reverses back, so it's a reversible thing, and it's not age dependent. Anyone can use it. The disadvantage is that several visits are required, and it's not a permanent solution. Coming to myopia control glasses, which is the upcoming trend now. So bifocal and progressive additional lenses were used initially, but it was found that when studies were done, the outcomes of these two were comparable to single vision lenses, and so for progressive myope, usually not preferred unless in the criteria mentioned before. The principle of the newer glasses for myopia control is that in a normal spectacle, the central light rays will be focused on the center part of the retina, and the peripheral light rays will be focused behind the retina. So this kind of gives us stimulus. This hyperopic defocus, it gives us stimulus, and so it causes axial elongation. The principle of the newer myopic glasses is that when these glasses are used, so instead of causing a hyperopic defocus, the peripheral light rays will be focused in front, causing a slight myopic defocus. And this is achieved by using additional plus lenses. So different technologies are there depending on different companies. We have Beams, Halt, Care, and Dot. And basically whatever the company or the technology is, the principle remains the same. The central portion will be clear area ranging from 5 mm to 9 mm, while the peripheral areas will be plus lenses will be added. This will give a slight myopic defocus. So this is the type of lenses, and several studies have been done to compare the benefit of this to the single vision lens, and yes, they were found to be significant. So the advantage is that it's 62% effective. However, it's very costly, and the starting rate is around 7,000 going up to 25,000 depending on the power and the company. Some of the patients may not be able to afford it. The most studied pharmacological medication for myopia is atropine, and then the most common studied dose is 0.01%. Several studies has been done for that, atom 1, atom 2. We don't have time to go into detail for that. Basically the exact mechanism is not known, but it acts by increasing dopamine and suppressing the eyeball elongation, or it acts on the scleral remodeling. The dose is OD, and emerging research we have two, that is red light therapy and methylxanthine. Red light therapy is we give it like 3 minutes twice in a day, and same mechanism, it acts by increasing the choroidal thickening and retinal thickening, which will kind of slow the axial progression. Then we have 7-methylxanthine, which is an adenosine receptor antagonist. It also induces thickening of the posterior sclera and collagen and thus slows down myopia progression. But these researches are still underway, and the safety has several studies have to be done. It's just one study has been done. So myopia control glasses, it just slows down progression. It does not reverse existing myopia or eliminate the need. So all this myopia therapy which I have said, we do it for around 2 years of stability, or we stop it when they cross 17 years of age. And basically the takeaway from here is that it's crucial to modify each treatment according to the child's need. Thank you.
Thank you, Dr. Awungshi. That was a very elaborate topic, but she presented it in a very crystal clear